at least. He had a bad fall about a month or so ago, and he's been left with a significant hematoma over top of his knee. This area is still excoriated, hasn't healed quite properly. But over the course of the last number of weeks, despite this being, now a month or plus out, the pain level is increasing for him. It's not terribly hot, so I don't worry about an infected joint, although he's had a joint replacement, so that makes us very nervous about this getting infected. But because this redness has been increasing and the swelling's been increasing, we're going to open this up where normally I wouldn't open up a hematoma. Sometimes we did. There's a case I put on the YouTube a while ago because it was for cosmetic reasons. This is obviously not for cosmetic reasons. And I want to be clear that I would not do this lightly. So I'm working with Dr. Jane again. Why would I not want to open up a hematoma?
Because it's sterile and we don't want to introduce
exactly it. So we don't want to create a worsening situation. This is sort of catching us from both ends. The pain's accelerating, which isn't a good sign for us, and we worry about is there an infection developing? Which right now I think is being kept at bay. And I should say as well, this duskiness, even despite the freezing being in, is there despite the fact that he's been on antibiotics all this time. So it's making us a bit nervous that his pain's increasing despite being on antibiotic, and we don't want this to get a deep infection. So we're going to see if we can open this up and then see if we can evacuate some of this hematoma. Now, from a freezing perspective, he has freezing all the way along this line. We're going to incise along his previous incision for the replacement. So there's freezing all the way around this. But we can obviously, for us to do a full circumferential block, we have to be freezing all this area, which would be a lot of discomfort for the patient. And when you have to squeeze something like this, it's going to be a bit uncomfortable. So we'll sort of see if we can minimize that as much as possible. Again, no pain there. That doesn't hurt?
Oh.
Okay. So for this one, I would use a number 11 blade. We're going to be puncturing as opposed to cutting with a number 15.
Right.
And we should be saying, what would we expect from this?
Blood.
Yeah, we expect like a blackish blood because it's been there for a long time. Doesn't hurt there?
No.
And on top of which it should be clotted, right? So it should be like almost like a red currant jelly type situation.
It is.
You okay?
Yeah.
Now the problem with this, you can see how thick that is,
Yeah.
which is what we'd expect. You're okay?
Okay.
So this is why he's having so much pain.
Yeah, that's very huge quantities.
So what I'm also going to be doing with this as well is getting a curette to see if we can break down any loculations that might be there. So I would tell you, my career, you see tons and tons of hematomas. The number of hematomas that I open up are very few and far between. See how much he has there? And this is probably why the pain's been just accelerating for him.
Yeah, it's probably too much for the body to absorb.
Well, and the other issue, the reason why I'm doing this particular case is with the redness and the dustiness been increasing, this hematoma is a great breeding ground for infection.
Right.
So this is why when it's not settling down, we do get a little bit nervous. How are you feeling?
Feeling good.
I can see how big one shift there. Not hurting too much when I do that?
No.
There's a clot sitting right there. There's a curette here. Doesn't hurt too much when I do that? Yeah, it's just what I'm fighting with now is just surface tension and kinetic pressures. So I should move this again. So I'm just breaking down the clot that's sitting right at the surface. There we go. You okay?
Yeah, I'll let you know in which vein.
So we just broke it down enough of the pressure within the actual clot itself that now it's starting to come out. So see, can you feel that there, Dr. Jane? You can feel his kneecap again, so that the pressure over top's released. We don't need to get all of this out, but as long as we get most of it out, then this will have a chance where his body can actually resorb the rest, and the pressure is released, so the pain won't be so much. And again, I can't emphasize that enough. This is not something I would do typically. It's only because he's had so long and the pain's accelerating, and then we were worried about secondary infection, that I would open this up at all. All right, I'm gonna syringe this.
Yeah.
Let's grab some of this for me.
You have a bunch here too.
So this I want to infuse with it. This is going to be 30 cc's.
One like these.
Maybe I'll put one more in. Not too bad. So this is, you can see how that's gone back down to normal. So what do you think in terms of suturing this back closed? It's not infected overtly, so it wasn't like pus with this.
Yeah.
So I think it's fair to close it somewhat, but I want to leave this with a bit of an opening.
Okay.
Can you grab me some chlorhexidine?
Yeah.
So just because we're doing this now, I'm going to do a bit of a swab here as well.
Dr. Fettler?
Yeah.
You just remember on blood thinners.
Yeah, well, I know. Yeah.
You got tile scars.
Yeah, and that's obviously a big part of why this happened in the first place. So here, whereas normally I would put in like probably, 4 stitches to seal it tightly, I'm just going to put 2 stitches in. So just so that this has a chance that if it needs to weep a bit, it can. And then we'll put a dressing on that. And the biggest thing here is we'll put a pressure dressing on this, because it's unlikely this will reaccumulate, because this is all old clot, and we didn't make a big incision and play around with a lot of tissues, so we're not going to create secondary bleeding. And so essentially this is just in place, so if it has a chance to heal back up together and just open right back up on them right away. But normally where these would be, twice as far apart, or twice closer, by half, sorry, and not so far apart, I'm just going to put the 2 in, and then we'll put a dressing on this. And is it less likely to get infected if it's more open, or more likely to get infected?
I think it's less likely.
Yeah, so that's the whole point, right? With these ones where there's some questionable aspect here, last thing we want is to be, in our effort to sort of try and alleviate discomfort and prevent infection, to actually create it. So if this was getting secondarily infected, we would want to be able to open it up and clear it back out. So we're just going to put a pressure dressing on this, and then make sure he's on the appropriate antibiotics, which he's already on, and then we'll go from there. So this is a follow-up of the knee hematoma that we drained. How long ago did we drain it?
Oh, last week.
Last week. So looks quite good, actually. It's like no signs of infection. The redness you can see globally is less. Feels less pain for you?
Yes.
Yeah, so that was the whole point. So this looks like it's going to be healing nicely for us. So you still see there's 2 stitches to remove there, so I'm going to be taking those out today, and then we'll just leave that alone. That should heal in nicely for us.